Welcome to the Women's Health Podcast. I'm Marika Hart from Hemisphere.
And I'm Anthony Lowe, the Physio Detective. Together we interview leading authorities, answer questions and share our thoughts to provide the general public with the best quality information we can find on all aspects of women's health. Please remember that our materials and content on this podcast are intended as general information and for entertainment purposes only.
They are not intended to be a substitute for professional medical advice, diagnosis or treatment. Now it's time to get cracking with the episode. So whether you're out walking your dog, driving the kids to school or just sitting back enjoying a glass of wine, we hope you enjoy the show.
Everybody, welcome to the podcast. Today we've got Robin Kerr with us. Robin Kerr is a physiotherapist of great experience. I met Robin in 2015 when I heard her speak at a conference. She was speaking about things that actually made sense, that were really practical in application. And I left the session thinking, oh, wow, that was really sensible and really helpful. And we've been able to be friends ever since. She's put up with my quirkiness and the things that I have passion about. And she's got some great ideas. And I thought, we thought, that it would be a great topic. Why is there still so much back pain? And talking about back pain and some of the reasons why back pain exists, where the research is taking us and what we can do about back pain. So that's going to be the topic for today. You can tell us a little bit about yourself, Robin, but with us today is our co-host, Marika Hart, and we've got Elaine Stevenson taking live notes for the show notes and the references. Thank you very much for helping us out, Elaine. So tell us a little bit about yourself, Robin. What's some of your history and your background for the people that don't know you?
I actually did rolfing before I did physiotherapy. That was way back, late 70s. Ran away screaming from that because for me, for my body, I just couldn't accept that that was the right thing to do to a body that was in pain, to hurt it. But I really did appreciate the way that Ida Rolf looked at bodies. So came back, I was in the military, came back, went into some actual grunt soldier stuff, decided that when I got married we couldn't have two soldiers in the family, so became a physio. And became a military physio to start with. So right from the get-go, my life was with young, fit folk who had to perform, very much performance-based. A lot of lumbar-pelvic work, it was just in the early 80s when the jogging craze was starting, so we were having a lot of our guys were doing a lot of running as well as running around in their boots all day, lots and lots of knees and foot. I did a lot of postgraduate training in biomechanics, in gait lab running assessment, got involved with international level sprinters, have been wrapped up with quite elite sport for the last 3 decades, predominantly with track and field and running, but also with a bit of team sport as well. So around 2000, we moved to Hong Kong. My husband's a pilot. Moved to Hong Kong, opened up a big sports practice, and then for some odd reason decided I'd had enough of that and became a pelvic floor physio and a low back pain and chronic pain physio. So since about 2000, I've been specialising in pelvic floor and persistent pain, which was a huge, huge jump from being a sports physio to what I'm doing now. And to be honest with you, I still do a bit of everything. I think I'm still managing. I think I've got 7 world champs at the moment I'm still working with. So that's a bit of a sidetrack for me every now and then.
So it sounds like you have quite the variety of clientele, Robin.
I do. It's interesting. I was just looking at my patient list the other day. I had elite level athletes coming in, and then I've got some little old incontinent ladies coming in. So I've got to sort of morph a fair bit during the day at work. Yeah. I'm currently too just training to become a psych because I'm moving out of physio. I've given myself a couple more years in physio and getting a bit messed up in the head because I'm still in physio but becoming a psychologist.
I could imagine those psychology skills would be very handy for all the chronic pain work that you're doing at the moment.
It is, and that's the reason I've gone into it. But I think the problem at the moment is that I'm becoming a little bit schizophrenic. You know, when I'm in the room, I can see that I should be more a psychologist, but I'm still a physio, and I have to keep practicing as a physio for a while yet.
In your scope.
Yeah.
Because we're going to talk about pain today, Robin, I think people have misconceptions about or misunderstandings about what pain actually is.
Yeah.
Would you mind just describing for our audience, you know, what is pain and why we experience it?
Sure. So I think it's become a very negative thing, but I think a good way to look at pain is that the system was designed when we used to live in caves, and outside there were saber-toothed tigers and things that would like to eat us running around. So the whole aim of the game is that our brains became protective and predictive. If we were injured or if we had some sort of problem going on, the whole aim of the game was to make us go back in our cave and lay down and stay away from the danger and wait until we were better, or hide until we're better, until we can go out, we can run away, or we can put up a fight. So essentially, we're working with a bit of probably outdated equipment. It's fantastic equipment, but it's a little bit useless for some of the modern day lives that we live. So essentially, it's protective. And the whole system's designed that, based on your prior experiences, that you're protected. It can be a really good thing. Having a pain process memory can be a really good thing, keep you out of danger in the future. But because of neuroplasticity, it can also become a little bit of a wind-up process, and it can become what we often find problems with is the more persistent or the chronic pain, which is usually what people would be coming to see a physiotherapist about. We get acute pain and a chronic pain. Acute pain is more just protective. That happens to everybody. You tread on a nail, you know, you hurt, you jump, you get over it. But the persistent pain is more to do with neuroplasticity, and it's very, very complex. I don't think we should look at it as a negative thing, though. I think we've made it a very negative thing. But I think we need to maybe change the way we think about pain and accept pain, I think.
Do you have to have tissue damage to have pain? Because I think a lot of people just associate, okay, I have pain, therefore there's something wrong.
Right. So a lot of times you can have an acute tissue damage, and we've got sensors in our tissues called nociceptors that send messages to the brain saying, do you think you need to have a look at this? Is this dangerous? The tissue sensors don't cause the pain. It's your brain that decides whether something you need to be protected from something by the generation of pain. But what can happen over a period of time is that there can be some changes in the system, a sensitization of the system, where you can be having pain, but there's no issue in the tissues, is the way I explain it to my patients. So it doesn't necessarily mean that there's something wrong in your back, in your muscles, in your disc, if you've got persistent low back pain. That's the tricky thing.
So just to clarify for the audience then, what you're saying is that if you've got low back pain because you bent over and you felt something go in your back and you got sharp pain, it doesn't necessarily mean that you've blown a disc or, you know, you've torn a muscle.
Just depends. It depends, you know, you can have acute fresh injuries. I treated a lot of those in the military. People were falling off ladders and all that sort of thing. But what tends to happen as time goes on is that the tissue can heal, but this protective, predictive process that your brain goes through to try and keep you in your cave and away from danger, there's a few other complex things thrown into it via psychology and the immune system, that will crop up, and you can have what feels like a problem in your back that feels very, very real in your back, but the tissue isn't causing it.
I think sometimes when we talk about the, you know, some of the science now that's around and some of the research, that when we try and explain about chronic pain and some of the changes to the central nervous system, so the brain and the spinal cord, is that people then interpret that to me, you're saying that
It's in my head.
It's in my head. So how do you approach that, Robin?
Yeah. Pain is real, and low back pain can be punishing. Persistent or chronic low back pain can be absolutely punishing. And I think when the pain science first came out and it was starting to be what we call pain science education was starting to be meted out by physios and pain clinics, I think the delivery was a little bit off, and it basically the take that a lot of my patients came in with was that they're telling me that the pain's in my head. And I can tell you that my back is hurting and the pain is in my back. And what I normally say to them is your pain is absolutely real. It's the way that the pain is generated is extremely complex, and we often have a bit of a chat about a lot of things that can contribute to persistent pain. Very often it's not that much to do with the tissues after quite a long time. We can talk about that a little bit if you want, about other factors that contribute. But one of the things that I often say to people is that since about 1990, there's been a 54% increase in low back pain around the world. So between 54%. So between 1990 and 2015, the low back pain rate in the world increased 54%. That's massive. So something's happened and something's gone on with that. And when you break it down, you look at teenagers, little kids under 10 don't have much back pain. But, 40% of teenagers, so from a 9 to an 18-year-old, 40% of them will have a bout of back pain. And within a 1 year period, if you look at adults, probably I think the number off the top of my head was 37% of adults have back pain. So, that's it's a common thing to experience. Unfortunately, I think what's happened is that we've medicalised it, we've biomedicalised it, we've blamed it on blown discs and torn muscles, and we haven't actually probably accepted the fact that pain's just a part of life, and it's become something that we try to chase and fix rather than something that we as a society just accept as part of living. Yeah, it's kind of an unpleasant thing, but it's just part of living. With those stats, I think the 54% increase in such a short period of time, I think we've got to be looking at the baby boomers. We've got to be looking at an ageing population, and we've also got to be looking at population explosion, probably in third world or lower socio-economic places. And in those sort of places too, you've got a lot of people doing some pretty full-on heavy work, maybe without the protections that places like Australia would have. So they're working in fairly poor conditions and not with the health and safety that we would have.
It's interesting, the statistics, I'm fairly confident, haven't really changed very much, but the increase in ergonomic awareness in occupational health and safety, work health and safety, has definitely increased since I learnt about it at university. Can you speak to where we've been in the past? Because, it was about alignment, about neutral spine, about lifting with bent knees and straight backs. And can you tell us a little bit about where we've been in terms of how we've been managing it and where we're going?
Well, we've been managing it from what we call a biomedical perspective, which is very biomechanical, very tissue-based. When I went through my training, definitely the Rolfing side of things was very mechanical. When I went through physio training, and I think it still is to a fairly high degree, all my training as a student was linked up to looking at the biomechanics of the spine, so what the discs were doing, what the joints were doing, what the muscles were doing. We started talking things like the core muscles being weak. If your core muscles were weak, maybe your back, that's why your back got hurt. And a lot of that now we realise it's too simplistic and too zoomed in, and it's only a really small piece of the puzzle in low back pain. So probably, I think probably in the last 8 to 10 years, where a lot of the pain science is coming through now, and there's definitely more of what we call a biopsychosocial push in the treatment of low back pain. I think a lot of therapists are still predominantly looking at the biomedical side of it, and that could possibly be why we haven't done so well, despite all our new MRIs and all our physios and people running around with PhDs and masters in all sorts of things, that the rate of low back pain or the suffering from low back pain may not be improving very much. And I think it's because we went down that mechanical route, and we need to zoom back out. We need to look at other things like the immune system and psychology, socio-economic, psychosocial factors as well, which is it's where medicine's going at the moment. The biopsychosocial stuff is, especially in persistent pain, is becoming the daily way people work. But it's a little bit on the slow uptake side. Everything in medicine takes about 17 years, and I think it's probably still another 10 away.
Can you explain what some of those concepts and words are, please, Robin?
Biopsychosocial,
yep. Contributing factors.
Yeah, so the biopsychosocial is when you look at something as complex as low back pain, there's different pieces that feed into it. So the bio is linked up to the tissues. The psycho is more to do with psychology, and the social is more of the society, the way that we live. So with the bio is pretty obvious, that they were talking about in the past. We would have talked about herniated discs and degenerative arthritic facet joints and wear and tear, tissue wear and tear. The psychological, we've separated in medicine. So, we as physios were tending to do, when I was training in the 80s and 90s and 2000s, the bio, and then you've got the psychs doing the other side of the psychological. And what we know now is that there's a very heavy link up to chronic or persistent low back pain with anxiety and depression, with tendencies to catastrophize, ruminate and go over and over the issues. We know that there's a huge impact on pain levels and health going into adulthood with people who've had adverse childhood experiences, what we call ACEs. We know it's much more complicated now. And for an example, with a low back pain patient who would come in to see me, very often one of the first things that I do, there's a couple of tools that I use that I can just very quickly see whether we have a lot of psychological possible contribution to the issues that they've got. There's a couple of questionnaires physios use. I tend to do it a bit more just through talking and asking questions. Very often, the experiences somebody's had as a child will heavily influence how their brain functions, and they are much more predisposed to developing persistent pain patterns. And that's one of the reasons I've gone off into the psychology. I find that quite a significant factor, and very interesting to work with. So, and the social stuff is just the way that society is set up, and the way that we function at work and how our institutions are set up, which at the moment, in Australia, we've got workers' comp. So you hurt your back at work, you're managed through it, hopefully with a physio. At the end of it, if you don't get better, there's disability or hopefully a return to work. I think we need to have a look at parts of that system. I think some of the disability pension we have in Australia is a little bit of an issue for people. I think we're looking at back pain as being a catastrophe that, a lot of people don't recover from. I think we maybe need to take a different look at it.
So Robin, on that note, just imagine you have someone coming into your clinic. Just say I come into your clinic, I've had an acute episode of back pain.
Yep.
What would be some of the things that would indicate to you that I'm more likely to recover quickly? Like, what would be some of the things that I say or maybe mention about my history that you kind of go, well, I think she's going to be okay, versus, and what would be some of the things that a patient might say that you kind of think, well, it's a bit more of a red flag for me. I think this person might be more likely to have persistent pain.
Sure. I think a lot of the research has talked about self-resilience. When you take a history off a patient, it becomes very obvious whether they are up and at it and look like they might be able to problem solve for themselves and to be able to push through a little bit of pain to get their rehab program done. So that is a positive factor. I think during assessments, we often ask people about their general health and how they've been travelling. And when people start to mention that they're taking anxiety or depression medications, or they've had a history of needing some psychology, that would be a flag to me. It's not necessarily a thing that's going to hold them up from getting better, but it's going to just be pointed towards that there's a little bit more of a complex picture going on here. And, very often you're... With acute back pain that comes in, you can see that there is a tissue-based element to it. It's quite obvious. Whereas with the more persistent pain, which is we're looking at things going on for longer than 3 to 6 months, years sometimes, it becomes a little bit more difficult, and it's often labelled non-specific low back pain because it's much more difficult to work out what actually is the pain driver. And there's a whole heap of tests that physios go through to try and work out which tissue is causing it. And very often we end up not knowing because it's much more complicated than the tissue stuff.
So to summarise so far, what I'm hearing you say, Robin, is that we know that pain is complicated, that there's been some new science come out that's been helpful in showing just how complex it is, and in the past, we've really focused on the biological side of things. So things like the discs and the muscles and the ligaments and alignment. And you've touched on thinking that hasn't really changed why there are so many people with back pain. And that there are other things like the psychological side of things and society and culture and the world that we live in and the contributing factors from there as well. With all of that in mind, and understanding that pain is really real, like you emphasize that all pain is real and that it's suffering, and that people aren't imagining it, they're not making it up. Where do we go forward? What's the science pointing towards? You've spoken a bit about resiliency, but somebody listening to this podcast might be in pain and they just want something to help because they're suffering. What are some of those things that they can do?
Right. There's been a lot of work done recently about where we go to and what we do, and the basic is to stay active and to understand what pain is all about. So, and that's something that physios or good therapists should be able to provide patients with. I think one of the red flags for a patient, if they are going to whatever sort of therapist they pick to see, if they're being given predominantly a biomedical or biomechanical or tissue-based explanation for their pain, especially if their pain's been hanging around for quite a long time, I think the patient as a consumer needs to start to be a little bit more discerning and maybe look elsewhere. They need to know that there's a lot, if they've got persistent low back pain in particular, there's a lot more involved in the tissues, and going to the therapist twice a week for 10 weeks and not really getting a whole heap better is a really common scenario for a lot of people. They kind of just accept that that's the way the thing works, and I think that's where things start to become quite distressing too, because they don't start to see the light at the end of the tunnel. Whereas if you turn up to see a physio or a therapist, any sort of therapist, and they said to you, look, it looks like you've injured this tissue. On the whole, things look pretty straightforward. We'd expect you to get better in the next 6 weeks. The science says you'll probably be feeling a lot better in the next 6 weeks. Probably you might find 2/3 of people we find still have some pain at 3 to 6 months. And, I think it's another 35% of people will have a recurrence of their pain over the next 12 months. I tell my patients the stats. But the thing to know is that your body unless you've got a lot of ill health, your body is designed to adapt and to heal itself. It's not a piece of machinery that breaks and may not be able to be repaired. Your body's a biological, adaptable organism, and we just have to work out the right input for it to move forward. And unfortunately, there are people who will live in pain. I think that's something that we don't accept very well. I think because of our biomedical approach, I haven't, my core's too weak, I'll have to get my core stronger, and it's my fault my back hasn't got better because I've got weak core muscles, or I've got to get a better medication. I think we've got to accept that pain is a some people call it a phenomenon. It's a emergence that comes out of us, out of our brains, that's so complex that we don't understand it yet, and that some people will be living with it, but there is always hope that you can live with the disability that you have from the pain. And I think we're far too fatalistic and always looking for a cure with medications or injections or finding another therapist. Sometimes I have people coming to me in the persistent pain clinic that I work in, and on the go, they've probably got 6 or 7 different types of therapists. They've often got a couple of doctors that they're seeing for medication and injections. And I think sometimes we just have to accept that's because we've gone up the wrong pathway, and we need to back it out, and we need to have a look at other things.
You mentioned movement and exercise, and
yes.
a lot of people that Auntie and I might talk to online, or even clients that come and see us. You mentioned it beautifully there, Robin, that there's this idea that I'm injured because I wasn't strong enough. If I do these particular exercises and do lots of bracing and squeezing of muscles of my core, that's going to protect my back and that's going to help me. So would you like just to talk a little bit about movement and exercise? And I know it's a massive area, but any sort of tips that you would give to someone who had persistent pain?
Sure. Yeah, I think it's always good to have a good therapist who can make sure that you've got nothing nasty going on. So that's the GP's job, and that's a good manual therapist or a good physiotherapist's job, to make sure you haven't got something actually biological that could knock you off. And that's not a hard thing to do. If we're well trained, and that gets done in the first session usually. I think the problem with the exercise is that, we're all therapists are humans, and everybody turns up with their own bias. The research is telling us that exercise, if you look at the research closely, doesn't actually have much better outcome effect than manual therapy, or manipulation. But there are a few other benefits to doing it. Yeah. And you get therapists who have got biases too. I've done strength and training. I'm a ex-Pilates instructor. I've done all sorts of physical, different types of physical training. You get people like Anthony who love lifting heavy. I think you do Pilates, is that right? Yeah, different people do different things. Okay, so I think one of the things that we have to let our patients realise, or build them to realise, is it's their choice. It has to, what they do with exercise has to suit them. I think too often, people go, well, get to Pilates, or come and do some heavy lifting, or come and do this, or come and do that. It's got to be what they want to do, and it's got to suit their belief system. And time again, I have people who have actually been caned, to get exercise done, and they hate it. So I think one of the really important things is exercise, is that you work with somebody who can meet you where you need to be met as far as with what you want to do. The other thing I think that some research is coming out about recently is we tend to be a little bit afraid of pain when we exercise. This is where you need somebody who really is quite good at what they do. I think possibly in the past, speaking as a physio, I think we went far too manually therapy orientated, too much passive therapy, too much on the bed therapy. I can fix you. If you come twice a week, I'll get you on the bed and I'll pop you back and I'll put you into alignment. That stuff can help. We know from the research that manual therapy gives you a window of relief. short term? Is it low value? I don't think so. I think manual therapy is really important. But I think what people should look for is that they should look for a therapist who can themselves take you through an appropriate exercise program, or they've got people who they can refer you to, or people who are in their clinic and people who they work with who can help you start to move. In the past, I think therapists on the whole have been afraid to move their patients into pain. I think patients are afraid to feel pain when they exercise, and a lot of the new research is coming out and saying if we've have this overprotective nervous system that is saying, oh, don't do that, that could hurt you, it's predicting that it might hurt you, you do get these negative, if you like, pain protection memories. And I think one of the things where we're moving to in the future is in the hands of a good therapist or in the hands of a good fitness professional, people with persistent pain to improve their self-resiliency, to stimulate their immune system, because immune systems like a bit of physical stress popped into them. I think we're going to have to exercise people into some pain. I think that's been missing. That's something that I've started to do over the last probably 3 or 4 years. And it's a matter of just meeting people where they're at and designing a program that starts from easy, lets them have a few wins, you know, that their self-resilience and their self-efficiency starts to build up, and then we go harder and harder and harder. So I think it can be a little bit tricky. I think people maybe can get flared up and get hurt if you're not in the right hands. So I think it's going to come down to a lot of training for the therapist, and I think it's going to come down to, you know, patients being fairly assertive and just finding the person that they need to work with. But yeah, I think we've been woozing out with that. I think you can I think you can help to reset a nervous system by pushing a little bit of pain through it, changing beliefs.
It really does depend on your population as well. You know, like I have a lot of athletes that have been pushing through pain.
Yeah.
And the summary of what I do with them is do something different. So if they're pushing through pain all the time, I tend to get them to hold back a little. And then if they're really scared of the pain, I tend to push them through a bit.
Yeah, so that's what you want. I'm talking about people who don't want to bend forwards because they were told not to bend forwards, and I can't bend forwards because the predictive protective pain comes on. So you know, just a graduated program, and not to be afraid of that. You know, if you're with a good trainer or a good therapist, you're not going to get hurt. You might get a bit of pain, but that's that whole thing about, you know, what is pain? You know, pain doesn't necessarily mean that your tissue is breaking or that there's harm happening. Pain is just your brain doing what it was designed to do to keep you in the cave away from the saber tooth. A lot of the time when it's persistent.
Absolutely. So for those people who are sitting at home listening, they've got back pain, or they've got somebody who they know that has back pain, should they just try and start doing more? We know, for example, that walking has just as good evidence. Like, what are some of the things that they can do without being, you know, like, obviously we recommend people go and seek a health professional, get a proper assessment, get some guidance. But also part of what all of that research that you're talking about says is that all those other therapies usually require somebody, and the reason why general exercise has some of the good things that you alluded to is because people can actually do it without having to spend money on things.
Absolutely.
You know, and particularly in America, where healthcare costs so much and hiring somebody costs money. What are the simple, effective strategies that you've worked with patients?
Sure.
You know, I'm trying to lead you to where I know you go. So what are some simple things that are missing in people's lives, Robert?
Right. The first thing that's missing in people's lives is their ability to regulate their own physiology. Especially when you've got persistent pain, your body tends to be in a fight and flight sympathetic nervous system area. So one of the things that we need to do is we need to get them to have the ability to be able to calm their nervous system down. And the easiest way that I use to calm a nervous system down is to find effective breathing. So slow, the type of slow abdominal breathing that they do in yoga or meditation or relaxation breathing, people don't realise how important being able to breathe in different ways in your body is. There's sports breathing, there's puffing and panting breathing, there's carrying the kids breathing out of one side of your rib cage breathing, there's off your feet, relaxed diaphragmatic breathing. I often find the first thing that goes when people start to struggle with pain is that their muscles tense up naturally around their lower back. Their tummy muscles tend to tense up. I actually very rarely find that people actually let their muscles go when they're in pain. They tend to tense up, and they'll go up onto their coat hanger, so they're up in their fight and flight and protection mechanism around their neck. So the easiest thing that I do is to make sure that they know how to control different zones of breathing, and straight away, you're controlling your physiology doing that. The next thing that I do, which is anybody can do at home, is human beings went upright onto two legs that are designed to walk. We're designed to walk, and we're designed to walk a lot. I think when you've got pain, preferably unloaded. So what I talk about a lot with my patients is if you can just on the flat, you don't have to walk hard, you don't have to puff and pant too much, but I talk about getting into, as you walk along, a little bit of upper body rotation. I call it swagger. So if you think about what's happening, if you look at those beautiful African women who have to walk 30 kilometres a day with a basket on their head to pick up some food, if you watch how they walk, they're elite level walkers. They walk with nice fluid rotation through their body. And if you look at the mechanics of that, there's a lot of nice fluid movement going through the lumbar spine. So in the physiology of it, that can actually help chronic or persistent low back pain a lot. All my persistent back pain patients, their number one go-to is go for a walk, go for what I call a swagger.
Robin, I'll just add to that, because I went to do a course with Robin. Was that 2 years ago or 3 years ago?
Yeah.
In Queensland.
2 years ago.
And
yeah.
that was one of the key things that I took away from that course, and I use it a lot. So thank you. I find it really interesting with a lot of new mums, because they're walking with the prams, and so they're often stuck in that very rigid upper body positioning, and then getting them to do that. So when the husband comes home from work or partner comes home from work, go for a walk and actually just doing that. And the number of clients, like within 1 or 2 catch-ups, to just saying, I don't have that pain anymore. And it's been quite a revelation, and they've actually gone on to teach their partners, who then their low back pain they have from sitting at a desk all day has gone away. So it sounds so ridiculously simple, but it's actually incredibly effective.
And it's very, very complicated. That's kind of just a distilled thing from years of watching runners and watching docs move on gait labs. You just see these repetitive Achilles tendinitises and chronic back pains in these marathon runners, and it usually came down to what the rotation was like in their thoracic spine, because it controls whatever else happens around the pelvis. So just to let the thing move the way the thing's meant to move is extremely important. So the breathing and walking, is that going to cure someone's debilitating, nasty back pain? No, but it's going to get them up and help them move a bit. I think I usually start with that, and then where we go to, I think we're meant to be. My whole thing, what I say to my patients is, we were designed to be out hunting and gathering, chasing and fighting and flighting and dancing around the fire at night and chanting and stomping our feet while we cooked our kangaroo. That's what calibrates our bodies, and that is not what we do on the whole. We tend to be a little bit too frozen up. So I often say to them, before you even think about, getting into any heavy duty treatment, find what gives you joy. And more often than not, a lot of people completely forget what joy is when they're in persistent pain. Like the whole family, everything gets a little bit hard going. And more often not, it's singing and it's music. We've got to get this brain to start processing in different ways. I treat a lot of people with PTSD. So what we know with PTSD is that their amygdala tends to start hijacking. And if we can get them into what we call their medial prefrontal cortex, which can come from exercising well and coping with a bit of exercise into pain. Often it comes from coordinated, rhythmic, well-timed movement. They often can have their medial prefrontal cortex start to modulate or downtrain the amygdala reflex. So, yeah, the PTSD stuff I find really interesting. And it's something too that I think goes a little bit under recognised, the amount of fighting and flight reactions that people live with 24/7 when they've got persistent pain. So chanting, no one whistles anymore. I often get my patients to sing, and I get them to actually just dance to their favourite music, even if it's very limited dancing to their favourite music. And people say to me, geez, that's really wafty and it's not really scientific. It doesn't mean that I'm not, getting them on the bed and doing, high level manual therapy on them, and I'm not doing high level zoomed in specific exercise, but what I'm doing is just letting their bodies do what their bodies are designed to do, which is, hunt, gather, dance, sing, chant, easy stuff. I think we forget about that.
So what
all those wafty, non-specific things.
So what I'm hearing you say is, from the physical side of things, that you see a lot of people, because when they're in pain, they go up into their coat hanger, they lock up their abdominal, they lock up their back, and so they start missing some of this motion, which you're just introducing back into their walking, something as simple as walking. So we're dealing with the physical, we're getting them up and moving, which we know is good for their mental health as well as their physical health, as well as their pain. From the psychological and sociological side of things, getting them to do things that they like, getting them to, so simple things like breathing, simple things like walking, doing activities that they love, doing social things like singing and dancing. These are all things that you're putting inside your treatment, and that's why it's a holistic biopsychosocial approach. Am I getting that right?
That's the physical side of what I do with it, but it's also, and this is a wonderful computerized, wonderful thing that we'll never understand up here, and it needs a lot of different input. With persistent pain, we talk about the neuromatrix, and it's got inputs and outputs, and there are things you can do to hack the input to a nervous system that is struggling, and things like walking with a swagger, and getting out in the environment, and correcting your breathing pattern. Breathing actually can be quite tricky to correct on your own, and very often you do need to have somebody who knows how to do that with your yoga therapists are often very good at it. So I think adding that into it would help, and I think realizing that it's okay to come out, get moving, and not be afraid to go and live your life, because a lot of my patients who come in, they've often been through years of physio or therapy, seeing lots of multiple practitioners. They've had failed back surgeries, they've had lots of disappointment, and I think just giving yourself a break and actually finding stuff that you enjoy doing. If you can go for a swagger on the beach, as far as I'm concerned, that's better therapy than I can give you. It's quite important. And all the immune system effects on we've got things called glial cells that get involved with pain as well. They all love going for walks on the beach. They all love going into the park and playing with the kids and all that sort of stuff. So I think we've got to not think that's wafty soft stuff. I think the physios and the therapists have got to sort of start to realise that we can introduce that a bit more.
Love it. I'm just thinking, Robin, I can see a book in your future that's going to be hacking your brain
for pain relief or something like that.
Yeah. Well, one of the other things that I do is I'm a TRE practitioner, a trauma release exercise practitioner. They're all over the place. It's an American psych technique where we teach people how to allow or how to trigger off their body's natural healing reflex. So I use it a lot with my persistent pain patients because it's one of those self-efficacy things where if you've ever been really frightened and you've had the tremors, or if fireworks go off and you've seen a dog shake, that's actually a mammalian healing reflex. Primitive cultures use it all the time. They stomp around the fire at night and all of a sudden someone starts shaking, and it's all very melodramatic and entertaining, but primitive cultures still use it. They use it to calibrate and clean out their, for me it's body hygiene all the time. We don't. If we get shaky and nervous, we tend to stiffen ourselves up and hold it. So what that technique is, it basically uses muscle fatigue in the muscles that would pull you into a fetal position, and we let the reflex come through and we teach people how to control it. So it's literally a full body shaking. They do it laying down. So things like that, that they could, people could look into doing things like that if they feel that they've run up a few dry creeks with their usual therapy, because that is hacking the brain. What you're doing there is you're changing the input and you're changing the output of what your brain's up to. There's a lot of stuff out there that we tended to have lost contact with because we've been too biomechanical.
I on the trauma release exercise stuff, I'm not trained in it, but I was, you showed me this thing and I experienced it, and I actually referred a patient to you to do a remote consult with, and when I saw her again, I said, so did you get in touch with Robin? Robin hasn't told me anything. She told me she looked something up on YouTube and has been doing it at home, and I'm like, oh, you got to be really careful with that sort of stuff. But like, she's been loving it because she's got a very highly stressful job, and she finds it really relaxing. But I told her, look, because you told me things like any sort of past trauma, psych issues.
Yeah, absolutely.
There's lots of things that you got to be careful of. So if people listening do go off and look stuff up and try it on their own, please be aware that there are things that you need to be careful of. Because, people will go off and go, oh, she mentioned TRE, let's go have a look at that. Yeah. And you can find stuff. I found the video, she sent me the video of where she followed the procedure basically that you took me through, and it's on YouTube. And
unfortunately,
that's what she does.
YouTube,
that's what she does. And it's
Yeah, it would always be good to have someone to guide you through the process and explain the neurophysiology and what's going on, because it really is. It's talking to the brain, but it's also mucking around with the spinal cord reflexes. And if you've got a therapist helping you do it, we can localize the reflex that you've got going on at the level that issues are at. So it's you're probably better to do it with somebody, but they're the alternatives. It's not a matter of walking into a clinic and someone telling you that your right pelvic bone's twisted forward and we need to push it back and then we need to crack your neck. It's not that. And we kind of, it might give you 10 or 15 minutes of relief and give you a window to exercise, but it's not going to be that. You have to learn how to work with your own body.
Yeah. Speaking about hacking your neural system, the inputs and the outputs, went to your pain course earlier this year, and one of the things you gave us all was this long poster, beautifully illustrated poster of all these different loops and inputs and outputs, and because we know about sensory nerves, we know about motor nerves, but we often forget about the autonomic nervous system.
Yep.
You want to speak about your poster and some of the things that are on it?
Sure. So that was the pain loops poster. And what I did, I'd drawn it 300 times for patients roughly, and I thought I'll just draw it up. So what it's all about, I'm just trying to see whether I've got one here. I don't think I've got one on me. I'm quite happy to, if you want to attach that to something with this too, Anthony, people can have a look at it. But basically, there's different things that feed into the brain that will determine what your pain output is. And the bio part of it's very small. We've got a whole heap of other factors that feed into the brain. Depending on what sort of the processing of the brain that's already going on, you'll get an output. Now, if you've had pain for 6 months and you walk in to see a therapist, and on the first day you start to understand why your nervous system's sensitizing like it is, if you understand that it's good to keep walking, that it's good to keep a little bit active, then what you tend to find is that you'll come out on a certain loop. If you go into a therapist and the first thing that they say to you is, oh, look at that, that's the worst x-ray or scan I've ever seen, and your pelvis is off and you're out here and you're out there, then that's what I would say would be going to take you on a negative pain loop, because we know from the research that stuff's not important that much. The alignment, the asymmetries and the postures really aren't that important when it comes to pain. Then you'll get, depending on what that first output is, it'll feed around and it'll go back into your brain, and your brain will do a bit more processing with it. So if you've had a really positive experience and you think that's I think I can get better, it sounds pretty positive, the threat level goes down. If the threat level goes down, if we can decrease the threat, then the protective predictive pain system will drop. If you leave there thinking, oh, she said I had the worst back I've ever seen, and it's going to take 10 sessions every month for the rest of my life, and I'm going to have to give her a direct deposit and sign up and keep coming back. We have therapists around us who do direct debits, and if patients don't turn up, they lose their money, and if they turn up, they get it. I find that disabling. I think that's a shocking thing to do to someone. But anyway, we've just got to make sure people get onto the positive loops, and a lot of it is common sense, and sometimes the common sense just doesn't come out in therapy. Sometimes I think. But I'm more than happy to send that to you, and you can attach it.
That'd be great. That'd be really handy. So, Robin, for people who've had a really significant experience with pain and they've managed to have that resolved, that is obviously a positive experience in the sense that they know that they were able to move past that. One of the things that I think was really important, what you said earlier about the fact that most people experience some pain, right? Like it's a part of life.
We all have pain.
Sorry?
We all have pain.
We all have pain. We all have pain. And so if they had that experience where they're able to resolve that pain and move on with life, then that can help with, another episode later on. Is that something that you address with clients? I'm just thinking like of a client I saw recently, and I actually said to her, look, the chances are in the next 12 months, you're going to have some back pain.
Yep.
That is not necessarily a sign that your disc is blown out or this has happened. It happens to everybody. We all have pain, but when you've had pain before, you can, I've had this myself.
Yeah, absolutely.
And the first time you get back pain again after that,
the
language,
very scary.
Is shit.
Yeah.
Shit. I can't do that again. And so what kind of hints would you have or feedback would you have for clients just to reassure them for their next episode? Because it's going to happen.
Yeah, well, I actually go into the pain science a little bit with them. I talk about the neurotags, so the processes in your brain that go, oh, I remember that when I bent forward and I picked up that bucket, or every time I bent, those protective things. I explain that they're there, and that that we have to override them a little bit. I've got a really good story that I tell my patients all the time, a bit like your back. I was an elite level swimmer. Lived with really rotten, painful shoulders for years on end. I went up to the Moscow Olympics and didn't swim after. So 1980, stopped swimming, and didn't actually get back into the pool. So I've had shoulder pain since I stopped swimming in 1980. And 2014 was just a shocking year for our family. I had 4 deaths in 4 weeks, including both my parents. After my dad passed away, he was the last of them who went. I was sitting on the bed. I had to go and organise the funeral parlour and all that sort of stuff. And I said to my husband, I can't get dressed. I cannot get dressed. And I literally couldn't lift my arms up. And I said, shit, I feel like I've been swimming in the surf or something. And I knew I hadn't. I've been sitting next to a nursing home bed for a few days. So what had happened is that the threat level for this month of stress had just gotten so severe that my neurotags for my old shoulder problem flared up. So my brain's way of protecting me from this extremely stressful situation was to light me up. And I sat there for about 5 minutes going, oh man, I can do without this right now. And I just gently talked to myself and I said, hey, not helpful. Come on, let me move. And within about 5 minutes, I was fine. But it was full on serious, couldn't get dressed. I was nearly going to have to go and call someone to help me get a bra on because I just couldn't get dressed. And to me, that was the best example of that predictive, overprotective, little thing sitting in your brain just waiting to come back. And I explained to my patients that may well be a factor with them as well. And, you know, if you've got other factors that are a little bit like throwing fuel onto the fire for them, you know, if somebody's turning up and they're having to deal with over Christmas who tends to trigger them a little bit, work stress, financial stress, all that is just petrol on the fire that might start to light up their protective system. You just have to be aware of it. Yeah, and easier said than done, but once you've overcome it once, the resilience is there and you can go, okay, I can work this out. Sometimes you have to get a bit of help from a therapist, so what? You can work it out.
I was going to ask, because when, you know, sometimes when these issues are brought up that other events going on in your life can increase your pain, how do you approach that in a way that doesn't make them feel like they're not mentally strong enough, or they're not coping and they're not, a lot of people feel like they're inadequate if they can't deal with all of this and keep going, and they've got this pain that's stopping them from doing things. What's some of the ways that you approach that type of issue?
Well, I basically, I talk to them like another person. I talk to them about, you know, life is not what we do in the West. So there's many components to us, and you just have to accept that your psyche, the way that we function is completely complex, and that many things affect it, and it's not a matter of being strong enough to cope with it. It's a matter that this is a protective, predictive process that goes on, and that it takes input from all sorts of areas, and that's just life. I think we've really, if you like, pathologized pain, and I think we have to just stand back as society and start to think of it more as just something that happens to all of us.
I know you do like to shake the tree, Robin. And so I like to shake the tree. I think that's why we get on. What are some of the characteristics, you know, Marika asked it earlier, some of those characteristics of things in therapists. Where do you think the future of physiotherapy, which is, you know, our common profession here, but future any therapy, chiro, osteo, massage, whatever therapist there is out there helping people at the moment, what do you think the future looks like? Can you see into the future 20, 30, 40 years and suggest what you think good therapy should look like now, really, but what you think will take a generation to come?
Yeah. I think at the moment it's still too much. You come and you pay me and I will fix you. What I would want, it's called interactive versus operator. So at the moment, I think we're a little bit still to operator. I will fix you. You come to me, I'll do this to you. Definitely, it's going to be a little bit more what we call interactor process. So I would just become part of your team, and I will help you. I'll help your leading, and I will help you along your way. So I think the power dynamics, the power asymmetries that exist in therapy should disappear. I think therapists, like I'm going to be cross-trained between a physio and a psych. I'm going to be practicing as a psych. I'm going to have my hands off, but I'm also a fit pro. Like I'm a highly qualified Pilates, and I've got all sorts of fitness qualifications as well. So I like exercising my patients. I like doing all sorts of things with them. So I think we're going to be the therapists of the future are going to be much more well-rounded. I think we're going to be one of the things that has cost me in the past as a therapist, and actually cost me 10 years ago, it cost me a partnership in a practice. I came back to Australia and I was working for somebody, and they thought the way that I approached patients was a bit weird. So it cost me the partnership, but I went and set up a good one anyway on my own. But I think we won't look like we do now, because we're going to be doing a lot of more generalised things. I never thought, when I was doing my MANIPS training in 1988, I spent 2 years learning how to crack backs and necks, that I would be sitting talking to my patient about stuff, what I would call waffly soft stuff, about sleep and, all that sort of thing. I never thought I'd be doing that. But in actual fact, most of the time now, I spend a fair bit of time talking, which is not what most physical type therapists would be trained to do. Interesting. I think the training is going to have to change. I think we might need to have an extra piece of the training for people to go through psych. I don't know how we're going to do it.
It's interesting. I was just reflecting on the fact that all three of us have postgraduate qualifications in
manual therapy,
and we don't actually do a lot of manual therapy.
Yeah. I think it's handy for me.
I don't think it's a problem. I don't think it's a problem with that.
Yeah, no.
I'm very much biased towards exercise and lifestyle modification.
Yeah. And I think the manual therapy, I think we need really good manual therapists. I think it's very good for clinical reasoning. I still have people coming in, and I do full manual therapy assessments on them, from that perspective, because it's my job as a physio to make sure that there isn't something bio there that has been missed. And that is a little bit of a problem with this new shift to the biopsychosocial too, because you're getting people fobbing people off and missing stuff. If there's a bio thing, we need to pick it up.
Tell us that story.
Which one's this one? The
guy who walked in. No, the guy who walked in.
The newest one. Yeah. I had I'm actually still in the middle of all this with him. You mean the spacer, the artificial disc boy? Yeah. I had a fella come in. I was in my lunch break and everyone was out of the clinic, and I had this fella come literally crawling through the door. He was a chippy, a plasterer. He was on a construction site, fell off some scaffolding. I think he fell about 12 metres onto concrete, hurt his hip and hurt his back. Went through a process with workers' comp. Don't bend, don't move with physio. It's very biomedical, very, no one really looked after his psyche at all. No one really realised that going through this whole 12 months long process that led up to having some back surgery, that he'd actually not been able to pay his rent, that he'd become homeless, and there was huge psychosocial pressure on him. He was actually living in the car park near the private hospital where his physio was in his car, because this has fallen apart. So, this is the conversations that I now have with my patients to know how they're going with all that sort of stuff. Anyway, after a while, because there was so much threat in his system, because he had people telling him that he should have been getting better and he wasn't getting better, and he was possibly malingering and wanting more medications, somehow he ended up having a back surgery and had two artificial discs inserted. Came out of that feeling a bit better, went through living in the car park, doing some full-on rehabilitation. After 6 weeks, started to say to the physio who was looking after him, I feel like I'm not feeling so good. I feel like my pain levels are going up. The physio assumed that he was after more meds because by then he was on a fair bit of medication. Went back to the surgeon for the 6-week checkup. Surgeon heard from the therapist that he was after meds and didn't do a check x-ray. So the disc had actually slipped forward about I think it's almost 2 centimetres, was pushing into his aorta. So this fellow basically was on this downward spiral and actually moved up to, this is all in New South Wales, moved to Queensland to be near his family. And just happened to come through the door one day because he was heading to the beach to drown himself. So all it took was me to give up my lunch break and sit down with him and actually just listen to the story. And then I sent him for an x-ray. The x-ray came back and the radiologist all of a sudden who took the x-ray was calling his surgeon, and he went back. They couldn't fix it, nearly died on the table. They put some screws in his back. Went to the physio. Physio said, just get your multifidus moving and don't bend. So this poor fellow, you know, I don't think it could have been done worse. So I was in a really difficult situation. I ended up just talking to him. I said, I'm physically not going to treat you. We need to get you to a good neurosurgeon somewhere else. He's been tested. They've told him they've got 3 vascular surgeons, the 2 neurosurgeons, told to come back home for Christmas and that he'll be operated on in the new year, and that probably 70% chance that he'll die on the table because he'll bleed out. So and he's going to go for it because he doesn't feel like he's got a life with the pain that he's living in. But the really interesting thing is I think if he'd had a biopsychosocial approach right from the get-go, people would have picked up that he was living in his car, and people would have picked up that he probably wasn't abusing his meds, and that x-ray may have been done. So that's probably the worst example of too much bio, and then jumping to the opposite extreme of just get on with it. And they were rehabbing him really, really hard. He was doing full-on rehab with. And
how long was that rehab going for? Like after the operation?
I picked him up at 4 months. Yeah, so he'd been pushed through 6 weeks. He started to feel like something had gone wrong, and he pushed through for 4 months.
But I think if I remember correctly, Robin, from that story, you felt that it was actually your manual therapy skills.
Sure. Yeah, he came in. He came into the clinic, and I said, "Look, just come and let me have a look." And I had a chat to him for about 20 minutes or so. So can I just have a look at your back? And I just had a little bit of palpation, a little bit of a feeling, and it was just nothing that I'd ever felt. It was very odd. And I said, "Let's get an X-ray." So there's always a place for bio, but I think that's where it becomes difficult. I think that's the reason I've gone off and done psychology as well, because I've got the bio side nailed, but I know that I'm not so good on the other stuff, so I've got to firm that up with myself.
And, you know, I'd said it on a recent podcast, you know, people are like pancakes where there's flour, eggs and water, and you can't just look at a person and say, oh, this is a bio problem, we're going to ignore the psychosocial. Absolutely. You know, like all of it is always mixing in all the time.
Yeah, all the time. Yeah. And, you know, I always say, I'm mentoring a few people now, a few physios, and I always say to them, look, I honestly know less now than I've ever known about persistent pain. I think I know my pain science really well. I think I'm up to date with all my research. I think I kind of know where I'm going with it, but I'm much, much more humble now than I've ever been. Just the way it works.
I think it's a really incredibly challenging area to work in, Robin, and I tip my hat to you because I know you deal with it a lot every day, and I have done a little bit in the past, but I do tend to work much more with, you know, pregnant ladies and acute postnatal type situations. So
that's important.
Which is really important, and hopefully preventing people from getting to that more persistent situation where I feel like if I can help them develop some of those those feelings of safety in their body, and they develop the resilience.
Yeah,
and
absolutely.
recognizing that their bodies are incredible, and they're resilient, and that they're strong, and that they want to heal. Your body wants to heal itself. It's incredible.
Absolutely.
These are messages. Actually, I say to my kids all the time, because when they have a little scratch or whatever, I was like, "Isn't it amazing? Look at what your body does. Look at how it heals itself. You can't even see what you did to your hand 2 days ago. It's amazing."
Yeah. They are. I'm amazed every day when I come to work. And now I've had some very complex disabled people, and they're back doing whatever they want to do now. It's just a matter of having the time and just working it out. There are others I haven't been so successful with, but I think I love this work now.
So, in summary, Robin, why do we still have so much back pain?
We're waiting for a shift in the thinking process, in the medical system, in society in general. I think there's always the issue of big pharma. One of the things I deal with here every day is opioid addiction. So we've just got to move away from the fact that we need a pill to cure our pain. One of the things that it's taken me a long time to come to the conclusion to is that we have to accept that pain's part of life, and that we need to find the people who can help us, or we need somehow to do it ourselves to move through. And I think we've got the other problem is that I will say we've got the problem that people. Like, there are clinics that everywhere people make money out of bio. People make money out of getting people on beds and pushing and stretching and popping, and I like it. I have massages, and I have my back mobilized every now and then, but that is our current model. It's biomedical, and to be honest, with the sort of work that I'm doing, I'm treating a lot less patients because they take me longer, and I'm making less money than I ever have. So I think that's a reason too. It's really hard, and that's a very complex and difficult reason. Having said that, we still need bio. As a sports physio, there's a lot of bio involved with that, biomechanics. We still need it all.
Absolutely.
The bathwater, right, Robin?
Yeah, I think that's and that's one of the things about social media. There are these big pendulum swings that people are on. A couple of years ago, people were saying, "Well, don't do manual therapy, lift and get strong." And you look at the research for that, and it's no different. So, yeah, it's complex, very complex.
Awesome, Robin. Before we finish up, is there anything else that you'd love to talk about, or that you'd love to mention about this topic? Because we're going to get you back to talk about many different topics. I love talking with you, and I always learn so much from you.
Listen, I think it's a crisis. If we've got, if we've had a 54% increase in back pain from 1990 to 2015, I think society as a whole, we're going to have to jump onto this. And I would love to go into schools and be talking to kids about what pain is and how to deal with pain. Not tell them how to sit up straight, and not tell them how to pull their tummy muscles in, but actually just teach people about what pain is and what contributes to pain, and talk about psychology and talk about autonomic nervous systems, fizzing, and how to down train autonomic nervous systems. I think we have to go about this a little bit differently. And I think there's change towards that. I've seen Lorimer Mosley's out riding bikes around Tasmania and doing pain education with GPs and people. I think that's great. Wafty and soft, and and weird is another word that I've been used with the way I work, weird, from other therapists. So wafty, soft and weird, way to go.
I think you said weird like cannabis, like get your patients to all smoke cannabis.
No, weird as if in this is not what we learnt to do at uni sort of thing.
We like a bit of weird, don't we, Anthony? Weird is good. Different is
Definitely. Different is good. I love weird.
So, Robin, if people want to find you, can you just tell us a little bit about where you're located or how people can reach you?
Yeah.
Maybe if they want to have an online consult or a second opinion or something like that.
Sure. I work at Alchemy in Motion at Noosa in Queensland. If you look up Alchemy in Motion, you'll get contacts to me there. I'm quite happy to work with people online. Yeah, I think I'm only working 3 days a week now, but I've got a couple of other days that I do other things. So, and in that time, I get online with people. So more than happy to give anybody a hand. And I think there's therapists out there as well, not just public people I'm talking to. So yeah, if there's any therapists out there who are not understanding where I might be coming from, just let me know and I can have a chat to you as well.
Fantastic. Look, thanks very much, Robin, for coming on the show. It's been fantastic to have your wisdom and your knowledge, and I know how much reading of the research you do, and I've been on courses, and I would say the only problem that I personally have on the course as a participant is simply the volume of information that you have to share. There's just so much that you want to share. You're very, very generous, and really appreciate you in the industry, and would never actually want you to stop doing physio because we need you far too much.
We do. We need you, Robin.
Sorry, what was that?
We need you.
I'll be around doing something.
Awesome.
Thank you so much.
You're welcome. See
Thanks
ya.
very much. See you later.
Okay. Bye-bye.
Well, that's it for this episode. Please be sure to hit like if you enjoyed this episode and leave any comments or questions below because we'd really love to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified of when we release a new episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.